I am super excited about this next panel. Your 2 a.m. Toolbox, evidence-based strategies to take home. I know we have a lot of questions already coming in, so if you have them, save them because we're going to do that at the end. But let me bring up to the stage our next two panelists, Dr. Shelby Harris, a clinical psychologist board certified in behavioral sleep medicine, an author and a clinical associate professor at the Einstein School of Medicine in New York City. Come on up. Hi. And Dr. Judith Joseph is a psychiatrist, author, clinical assistant professor at NYU, and chair of women in medicine at Columbia. Hi. All right. So this is going to be a great conversation. And I know, again, we'll get to the questions at the end. So I want to just jump in and get started. And Dr. Harris, I'll start with you. Let's talk about the common mental health symptoms during perimenopause. And do we see different mental health symptoms in postmenopause?
Yeah, I think there's a lot of changes that happen. And when we talk about it as being a perimenopause, menopause thing, yes, there are hormonal changes, but it is also a stage of life that is rife for many changes in general. So we have stressors, aging parents, kids. We're pulled in 8 million directions. And then you have the hormonal changes. So we see a lot more mood changes like depression, anxiety. We might see that brain fog we were talking about, trouble with concentration. You might see motivational issues. So we see a lot of those changes. And what was mentioned in one of the earlier panels, that some people might start noticing that medications they might have been on for a while just don't seem to work in the same way that they had. So there are definitely things that we think of that's change. And then sometimes when you go into postmenopause, some of the things can soften, like the irritability, the mood swings, things like that. They don't always, but sometimes it can soften.
And then, of course, you lose that filter too sometimes in that postmenopause era, as I've become very familiar with. Oh, I don't need a mic. Okay, sorry. Judith, you have a mic. All right. So Judith, let me go to you. Dr. Joseph, let me go to you. How can menopause impact us cognitively?
It's a great question. And many people don't know this, but most of the early symptoms are related to cognitive issues, but we don't know. We just think that, oh, I must be tired. I'm getting old. I just can't do this anymore. But these are the sneaky, quiet symptoms. So with my clients, I like to educate them about something called the ties of mental health and menopause. The T in ties is the thinking, right? These are things like having memory problems, tip of the tongue, losing a word, having problems with organization. I heard a lot of ums. The I is the identity issues. There are only recent new studies talking about this. I don't feel like myself, like that's something that's really hard to quantify, but a lot of women will say this. And this could be due to changes in your body, your thinking. You just feel as if you don't know who you are anymore, but it's very distressing to my clients. The E is emotional issues. So things like symptoms of depression, symptoms of anxiety. They're not true clinical diagnoses usually, but they're symptoms, right? So up and down mood, irritability, feeling tense, worrying excessively, so much so that it wakes you up at night, which takes us to the S, sleep issues. And that's where Dr. Shelby comes in. Sleep, no pun intended, ties it all together. If you don't get good sleep, then you're going to be cranky. So that impacts your emotions. You're not going to think clearly. That's the T. And you don't feel like yourself. That's the I. So the ties really helps you to identify these sneaky symptoms that tend to come in first.
I'm so glad you brought up sleep because I think that's just one of these big ones that that's one of the, I don't know, it's what I probably notice first with everything. And then I also notice cognitive and just brain fog. So Dr. Shelby, let me ask you, how does sleep impact us cognitively, first off?
So sleep can really impact you in so many. I always talk about sleep being the bedrock on which everything else is built.
Yes.
So when you're not sleeping well, it really can impact your ability to think clearly. That brain fog is worsened, as so many of us will notice. You might find you might have short-term memory issues. You might have trouble just kind of getting that tip of the tongue. The words, right, might not come to you as well. And also just when it comes to longer-term cognitive function, we do see that when you're sleeping well at night, guess what? It washes out some of the the plaques, the proteins that are built up during the day that can actually help with memory long term. And if you're not getting enough sleep, you have more of that plaque built up, which is what we're starting to see a little bit in the research on sleep and dementia longer term.
I know you have a lot of tips that you're going to bring us for sleep, how to get to sleep, how to stay asleep,
Yeah.
how to figure out our sleep hygiene. There's so many different things. So Dr. Judith, let me ask you this. There are a lot of different acronyms out there when we talk about CBT and DBT, and you do a great job of really distilling those down so they're understandable. Can you explain exactly what behavioral therapy is?
Yeah, I mean, the issue is that we don't really think about therapy in terms of methodology. We just think that it's you just go and talk to someone, but there are so many different types of therapies out there. Behavioral therapy is based on the principle that behaviors are learned, right? We're not born with these behaviors. So cognitive behavioral therapy is one in which there's a model that most of us know about where the thought may lead to a feeling, which then leads to a behavior. And so a lot of times when you're working with a therapist that you trust, you're focusing a lot of your efforts on challenging these thoughts that may be very disruptive and increase a lot of stress in the hope that you somehow change the way you feel and then the way that you react. Other types of therapies have different methodologies and are more mindful based. So, for many people, you may feel dysregulated. And things like dialectical behavioral therapy allows you to really hold on to the fact that, two things can be true, and that's okay. You validate how you feel, and then you use distress tolerance skills to help you to get through a difficult situation. And then ACT therapy focuses on helping you with a more flexible approach to prioritize what's most important. And, many therapists out there will say they use a little bit of each and they blend it together. And that's why it's important to find someone that you feel validated with, someone who listens to you. If you go to a therapist and it doesn't click, then get a second opinion. You have to be able to trust this person because this is a very vulnerable point in your life and you want to feel heard and you want to feel seen and you want to feel supported.
And can I add to that just really quick? So if you're looking for someone, because this is something I hear a lot, is like, oh, I'm not sure if I'm actually getting cognitive behavior therapy or I'm not getting DBT. Go to those societies. So like the ABCT, I always want to say it opposite, but ABCT, for example, will have a list of people who do cognitive behavior therapy. You want to ask, like, what kind of training have you had in that area? Because you want to make sure that you're getting what you're asking for specifically.
So let me stay with you for a minute and let's talk about this, the emotions, the thoughts, behaviors, and the bodily sensations and how they connect to one another and where that's relevant in menopause and perimenopause.
Yeah, I think I'm going to talk about it a little bit on like sleep, for example, but if you're having a thought, right? We all have thoughts throughout the day. We have so many thoughts, but those thoughts sometimes can be positive, they can be negative, and they're going to lead you to feel a certain way. And then if you're feeling a certain way, if you're feeling down, you might start to focus more on physical sensations that might be going on. And then start thinking about how you might be aging and how things that might be ending, or it might make you go to worst case scenario, which is then going to lead to certain behaviors, maybe avoiding people, avoiding a significant other, whatever that might be, which is then going to lead to the thoughts again. So they all cycle around and influence one another.
I know that this is a conversation we talked about a little bit earlier with regard to mental health and medications, but can you go into, Dr. Judith, let me start with you on this, and then Dr. Shelby, if you want to jump in. How do medications for sleep and mental health fit in here?
Well, everyone is different. We all have a unique fingerprint, right? And we all have a unique biopsychosocial. And the biopsychosocial is really important. It's a tool that most of us learn in medical school, but we're starting to talk about it in terms of letting patients do their own biopsychosocials. In fact, that's what I'll do in my office. We'll draw little bubbles. So biologically, what are your medical conditions? For me, personally, I have a thyroid issue. So I have to think about my thyroid and sleep. But some people in here may have autoimmune conditions. Some people in here may have obstructive sleep apnea. All of these things play a role. Psychologically, what is your past psych history? Do you have a history of trauma? Do you have a history of ADHD? Do you have other mood conditions? And what are your social factors? What is happening in your social environment? Are you taking a lot of caffeine? Are you doom scrolling, when you're supposed to be letting your brain rest? Are you in stressful environments with a partner or at work? And what are your habits? Are you sedentary? So when you do your own unique biopsychosocial, your doctor is or your healthcare professional is better able to pick a medication to support you. And so, for someone who, let's say, if they have ADHD and they're on stimulants, well, I'm going to think about that and whether or not they need to have a decrease or an increase because that can interrupt their sleep. But things like antidepressants, like venlafaxine, have been well studied in the mood component of perimenopause and menopause. Some sleep aids like Remeron or Trazodone that are non-habit forming are regularly used temporarily, but you want to think about avoiding things like benzodiazepines for long-term use and things like sleep aids like Ambien and so forth for long-term use because some of them are associated with, a risk of dementia over time, and also they can be habit forming. So really think about your biopsychosocial and your individual needs when you're picking medications, and try to stay away from ones that you could potentially become have habit forming medications.
Dr. Harris, do you want to add anything?
So I was just going to add to that. Yeah, we always want to think about the individual, right? One thing that we do try to do, at least because I'm in the sleep medicine field, the thing that we really try to do before we start people on sleep aids necessarily, or we really do try to do something that we'll talk a little bit more about called cognitive behavior therapy for insomnia. So that really has been a game changer for a long time in sleep. It's just people still aren't talking about it, and there aren't a lot of people who are specialists in it. So to really try someone on a short-term course of CBT for insomnia is usually the best course of action before we start going down the medication route. We always think about sleep aids because as you get older, then there's a greater risk for memory issues, falls, accidents. If it's working for you now, is that going to be the solution for you 10, 20 years from now when then you have no other strategies to necessarily rely upon?
So I know we want to make sure that you all have a toolbox to kind of take home with this panel, especially, and dive into two areas in particular, which is sleep and brain fog. So let's start with this. We mentioned sleep hygiene. I know we hear people talk about it and there are some different tips, but what exactly is sleep hygiene? And then I want you to talk about the difference between that and CBT.
So sleep hygiene, the term, I always think about it like dental hygiene. My colleague Rachel Mamber once said that. So okay, you're going to brush, you're going to floss every day to hopefully help with gum health, right? Preventing a cavity. But what happens when you get that cavity? Are you going to keep brushing and flossing it to go away? And is your dentist going to say, stop brushing and flossing until I get you in a week? No, you're going to keep brushing and flossing, but that's not going to fix the cavity. So sleep hygiene, limiting alcohol 3 hours before bed, limiting the caffeine, trying to keep a consistent sleep-wake schedule, all those things are helpful. But that's not going to fix an insomnia if you're having trouble sleeping multiple days a week. I cannot tell you how often in my office, everyone's like, I do everything right on the list that they give me. It's because you're not actually doing the treatment that's going to help with the insomnia. It doesn't mean you should drink a 2-liter bottle of soda before going to bed. Now, CBT for insomnia, sleep hygiene is a piece of it, but it's not most of it. It's limiting time in bed. It's working with the practitioner who knows to actually spend less time in bed, to work on the thoughts that you're having about sleep. It's working on things that you're doing in the middle of the night, trying to go back to sleep. And it's a very short-term treatment. I see people once every 2 weeks for 4 to 8 sessions, sometimes a little longer if we're tapering off of meds, but it's very evidence-based and it goes way beyond sleep hygiene.
And that would be even if you have a sleep apnea or you have something else you're dealing with?
You can do it along with sleep apnea treatment. A lot of people have what we call COMISA. They have insomnia and sleep apnea is super common in women once they hit perimenopause. So if you're getting kind of brushed off and you have pauses in your breathing, it doesn't have to be like that kind of noise. Definitely get it evaluated.
All right. So I know you're going to walk us through a strategy to utilize in everyday life, and you have a demo. You're going to demo your favorite tool. So let's take it away.
So who here has heard of cognitive therapy, reframing thoughts? Okay, so not many of you. So the idea is that like that kind of cognitive model we were talking about earlier, right? Thoughts lead to an emotion, lead to a behavior. Who here has had the thought in the middle of the night, if I don't sleep, I'm not going to be able to function tomorrow, right? I know, we all do, right? And so what do we end up doing? We end up trying to force ourselves to get sleepier, and sleep is not a problem you need to be forcing because it just makes it worse. So instead, teaching yourself to rationally evaluate the thoughts that you're having is going to be key. So if you have that thought, if I don't sleep tonight, I'm not going to be able to function tomorrow. I encourage everyone to think about this, first of all, during the day, not at night. Because one thing also to think about is that at night, this is true, your prefrontal cortex in your brain is actually, it's dimmed. And this is what's responsible for judgment, decision-making, right? Cool tip is that when you're dreaming at night, this is turned off, is more so turned off. That's why we don't judge ourselves when we're dreaming, right? Crazy dreams. So don't do it at night. Start during the day. So if I don't sleep tonight, I'm not going to be able to function. First thing you need to do is get very specific with what function means to you. Everyone has function means something different to everyone. So I won't be able to speak coherently at my job. I won't be able to do the presentation the way I want to. I will be, and even the one I hear a lot is, I won't be a good mom to my kids. What does that mean, right? I'll be more irritable with my children. Now, the next thing you need to do is, and if you go online and you look up a dysfunctional thought record or a thought record online for cognitive behavior therapy, you'll get a whole list of questions you can ask yourself to challenge it. It's not positive thinking, which is what a lot of people think it is. It's realistic thinking. So if you're someone who has the thought, let's just say at work, I'm going to get reprimanded at work because I won't do this task very well. Out of all the nights that you have that thought that you're not going to be able to function, what's the evidence that that's actually true? Usually it's not. Or if it's true, it's not 100% true, right? We kind of get very black and white thinking. So try to evaluate how true that thought is. And then what's evidence against it? Okay, out of the 10,000 nights I've had poor sleep, I've only once ever been reprimanded, right? Think about it in that way. Another thing you could say to yourself is, what would I tell a friend who's in the exact same situation? Right? Who's worried at night that they're not going to be a good mom the next day, that they're going to be irritable with their kids. What would you tell them? And why do you hold a different rule book for yourself than you would hold someone else? Right? Another one could be, what could be the effect of changing my thought? So if I actually change this thought, what could happen? Maybe I'll sleep a little bit better because I'm not going to be so worried about it. So if you tend to have the same thoughts night after night about function or about your parenting, whatever it might be, then the next step for that is to write a coping card. So on one side, write the thought that you usually have. And then on the next side, write the challenge. So what is that honest challenge that you have for yourself? And put it on the other side, and then just put it on your nightstand. Because remember, that rational part is hard to access in the middle of the night. So it's almost like you're looking at your rational self during the day, being able to challenge that thought at night. And it can be a really powerful tool. Now, the one last thing to add is, like I said, it's not positive thinking. If you actually have trouble with these things because you're not sleeping, you're not doing well at work, you're getting reprimanded, maybe car driving problems, whatever it is, then you need to start problem solving it. Okay, what can I do to cope with the fact that I'm not sleeping? So it's not positive thinking, it's rational thinking, and then problem solving if need be.
So let's talk about a couple of the behavioral changes or techniques we can take home today, because there's one in particular that's made me feel so much better, which is the limiting the time in bed.
Oh yeah. So I always say, when it comes to insomnia specifically, trouble sleeping multiple nights a week for multiple weeks on end, what we all try to do is the common sense thing is like, let's go to bed earlier. Hopefully tonight's going to be the night I catch that sleep because I'm so tired, or I'll sleep in the next day. That's actually what gets you in trouble. So spending less time in bed is actually going to help you to sleep more. And there are ways that you can do it. We call it time in bed restriction. I have a book that talks all about how to do that. I do that on my Instagram. I talk about it. But try to spend a little less time and you might find you'll fall asleep a little bit faster. And then one other thing I add in is, don't watch the clock at night. So if you look at the clock, the thing we hear, the 2 a.m. toolbox, right? I wake up, I check the clock. Well, you're training yourself to look at the clock and know it's 2 a.m. And then finally, if you wake up and your mind is active, do a little bit of meditation practice, 5 minutes. That's it, during the day. Not the nighttime stuff with Harry Styles to fall asleep to, daytime stuff. 5 minutes, let those thoughts go, refocus over and over again. If you practice that, even starting today for a few minutes during the day, every day, in a month or two, it'll get easier for you to soften those thoughts that happen in the middle of the night when you're up.
I think of you often in my bedroom, Dr. Shelby.
You're not the first person who said that to me.
Right. Who here has had problems word finding or brain fog or, oh, Dr. Judith is here for you. So Dr. Judith, let's talk about some specific strategies that we can take home today.
Yeah, because I treat children, adolescents, and adults, I often have women in midlife who are the parents of my teenagers with ADHD saying, I think I have ADHD now. And it may be the case because we know that girls tend to be underdiagnosed because, technically you have to have inattention and hyperactivity, but a lot of times boys show the hyperactivity and girls show the inattention, so they get missed. But not to say that there aren't ADHD cases in adulthood, there are, but most of the time, what I end up seeing is brain fog, and it's that sneaky symptom that comes in. And so, one of the tools that I use is called planned. So, you can write this down. So, PLANNED. P is for prioritizing. Many times we are the mom, we are having our careers, we are taking care of our elders, but make a list of things that are priorities. There are so many things that we try to do all at once, but multitasking really puts a strain on our brains and we don't do any one of those things well. So make a list and prioritize those things. One of the things I use is the Eisenhower matrix. It's a decisional tool that allows me to focus on things that are really important and to delegate things that are not as important. And Google it. It's taught at most business schools, but most people have never heard of it. And President Eisenhower used it a lot when making his decisions, and I love it. So the L is a launch pad, and launch pads are things that you can keep in your home or your office to put the typical go-to things. In my family, we joke that I'm always looking for my earbuds. So I have a bowl on the table where I put things like my earbuds, my keys, my wallet, things that I'm constantly losing, like glasses. And I have one of those in my office as well. So keep a little launch pad in areas where you tend to lose things. When you have less time in the morning, looking for something that's lost will completely dysregulate you. And then your day is started off on the wrong foot. And then the A is for aids. So the aids that I tend to use, because I am a little bit of a cluttery person, is I use these containers that are color coded. And in ADHD, this is what I do with my teens. Like we color code things to be able to find things. It decreases the decision-making time. So you know where certain things are. We do things like file systems, but you can do this with containers. You can use aids in your workplace, such as like little stackable areas where you put certain things that you need to use repeatedly. The goal is to use things in your environment that you can touch and see. So you're using sensory components to organize yourself, right? The first N is my favorite. It's no. Set boundaries. Get comfortable saying no. Initially, you feel guilty, we're people pleasers often, but try to set healthy boundaries and say no to things that are not important, because the more you add to your plate, the more overwhelmed you are, the less you make worse decisions. You're more stressed, right? And then the next N is new, for new technologies. And with my elderly patients and some of my older patients, I'll use very simple tech to help them stay on task. So things like digital pill boxes to remind you when to take your medication, but there are apps that will help you to stay on task for certain things. So you don't miss doctor's appointments. So you don't miss out on, things that you need to do that day. Don't be afraid of new technology. And one of the important things I do is I try to shift my patients from paper bills and paper type of documents to electronic bills, because it's less on the system. If you think of your brain as a computer, then you're putting too much on that system if you're constantly trying to keep it all in here by yourself. So use these new technologies. The E is emotional support. So one of the tools I use is a body double. So what I'll ask my patients who have executive functioning challenges is to find someone who they can work with. So if you have a deadline and you're finding it hard to stay on task, ask a friend to sit with you and do it at work, or at home, ask your partner or your family member to help you declutter. Having that support is helpful, in addition to a therapist if you want to do that. And then the last part is D, for decluttering. Get rid of things in your environment that are getting in the way of the important things. So I'm going to ask you to look in your purses today and tell me how many of you have receipts that don't need to be there. right?
Yeah.
So many things in our environment clutter us and they just create more obstacles for getting things done. So declutter your closets. They're your go-to outfits, put them in one area so you don't have to spend a lot of time with that. Just try to simplify your life. Planned is something that we can all use. It's taken from ADHD organizational skills, but I use it for any of my clients who have executive functioning challenges, and it really works.
Oh my gosh, I need a launch pad like in 3 places right now. I love that. That's just, it's great. I know we're going to introduce the concept of acceptance and self-validation to Dr. Judith. Can you do that?
Yeah, so, if you were in a dark room and you couldn't see anything and you heard a loud crash, some of us would start swinging, some of us would start screaming, some would start running, right? But if you turned the light on and you saw that it was like an inanimate object, a vase that fell and crashed, you'd be like, oh, I'm safe, I'm okay. So acknowledging how you feel is really important. It's like turning the light on.
Mhm.
There's a term in psychology called affect labeling. When you can name what you're going through, what you're experiencing, what you're feeling, that in itself is a therapeutic intervention. You know what you're working with, so you feel better. Human brains don't like uncertainty. So let's say if you're in the middle of a hot flash or you can't remember what you're about to say and you're starting to get really stressed and that cortisol level is rising, it's okay to acknowledge and accept how you feel. Oh, I'm having that tip of the tongue thing, or I'm having this physiological feeling that's uncomfortable. You're accepting it. And slowly over time, if you use these self-regulation skills like deep breathing, mindfulness, you'll be able to ride that wave and calm down, right? But what happens is if you don't know what's happening or you don't accept it, you're trying to fight it, then that just causes this vicious pattern of self-dysregulation. And it's not to say that this is not happening. This is very real. What's happening to you is real. We believe you. But accepting it, naming it, and then using your skills will help you get through that much easier if you were to deny it, try to fight it, and then you spend all this energy and it's just making you feel worse.
Yeah, one of my favorite ways to think about acceptance is like there's an image of an umbrella and someone's standing outside and it's raining and they have the umbrella over them. One person's like, "Oh, I hate when it rains. It makes my hair frizz and then I get everything wet and all these problems." And then the other person is just standing there with the umbrella and they're like, "Yep." So you're just like, okay, it's raining. I don't have to love it, but it's raining. And I think that if you think about it that way, that isn't of its the essence of acceptance. It makes it a little easier.
I guess I always think about this time in life is like there's so much coming at you.
Yeah.
There's so many different parts of your life, whether it's career, whether it's kids or it's taking care of parents. I know. Oh, and by the way, perimenopause might last for 10 years. So those are like all the things that are happening at the same time. And I think
Yeah.
in you're not sleeping, and now you've got brain fog. What is the first piece of advice? When we have those are some great tools that you both gave us. What is the first thing to maybe really focus on? If somebody said like, I want to implement this tonight, is sleep where the core would be of at least the sleep hygiene before you can go into CBT?
Yeah, I think sleep hygiene is a great thing to do. If you do it for 2 weeks, maybe
Yeah.
even take out like a diary, right? I have one in my book. There's a million online. Track your sleep. Just kind of say, okay, how am I sleeping at night? And then does alcohol impact it if I limit it? What about caffeine? If after 2 weeks, it's not making enough change for you. And also, one other thing I would say is make sure you're getting up at about the same time and going to bed about the same time. Inconsistency is worse for you overall than even amount of sleep. Consistency is key. If that's not enough, then you want to start looking into other things like sleep apnea, restless leg syndrome, insomnia, things like that.
Okay, and we're going to get to Q&A, I promise. Dr. Judith, I just want to ask you one more question. When we talk about brain fog, we talk about like that tip of the tongue, like I know the word, or you just don't have that recall. Is trying to figure that out more frustrating? What do you do in situations like that? Because I think a lot of people deal with that at work and feel very like a lack of confidence as a result of that. What do you suggest?
Yeah, for those very common experiences, I always ask my clients to have a canned response ready. And so it's similar to a coping card. You know, you have your response ready. So if you can't remember what you're saying, you may have to say, oh, you know, this tends to happen. It's not a big deal. I'll get back to it. But it could be something else for someone else. Whatever feels authentic to you is really helpful. And then having those really simple grounding techniques, because let's say you're in a meeting and this happens. For many of us, we start to freak out. But if you have your go-to skills that you use to stay centered, for me, it's a deep breathing, but for others, it could be a 5, 4, 3, 2, 1, just like a to keep you present. Use those. Practice them before you're in that situation so that they are your go-tos once you're experiencing it. So you first you have your canned response, and then you have your canned skill. And then you realize that, you know, in hindsight, it wasn't that big of a deal. But in that moment, because there's so many things happening, it feels more intense than it is. And that's why when Dr. Shelby said practice it before it happens, it's super powerful. One tool that I use for my clients is the worry journal. So like it basically they're procrastinating their worry. So what I tell them to do is if a worry pops up during the day, tell yourself, I have a worry corner for that. I'm going to procrastinate my worry. And pick the place. It could be a part of your home that you don't frequent a lot, a part of your office that you don't frequent a lot. But that's the place you're going to go and you're going to worry in that corner, right? That's your worry place. What happens is that you end up training your brain to hold those worries for that corner. And by the time you get there, you're like, wait, why was I worried about that? That wasn't a big deal. This is like a new type of therapy. It's metacognition. It's really, you know, taking form in UK, but it's spreading here. But you're not saying that the thought isn't there. You're imagining that that thought is like a cloud. It's there, but it's passing by, and you're not going to engage with that thought, but you have a specific time and place for it. And when you get there, I mean, I do this to myself all the time. But when you get to that corner, you're no longer worried. So you're training your brain that you can have control over these thoughts. They don't have to rule you. You're not saying the thought isn't there. You're saying, I'm just not going to choose to engage with that thought right now because something else is important.
Thank you for sharing that. That's great. Okay, let's do a little bit of Q&A.
I'm going to see a menopause doctor in 2 weeks. Her name is Dr. Camilla Smith. If anyone has experience with her in here, please let me know. Okay, that's a good sign. I've been wearing this Aura ring for 3 months, and it basically says deep sleep for me varies from 3 minutes to 27 minutes. I once had my daughter wear it just to make sure it wasn't broken, and her deep sleep was almost 2 hours. And so I'm taking, you know, all the magnesiums and, you know, to sleep and to poop, and I'm taking the melatonin and I'm taking the ashwagandha and all the stuff. Any thoughts about all those supplements and the deep sleep specifically?
I could talk about this for 8 days.
Okay, let's go.
Okay. So here's the thing with all the rings, the trackers, they're great for people who don't make sleep a priority, right? So if you're someone who's like, okay, I'm just like going to bed at different times and I'm having some alcohol, let me see if it impacts my sleep. Perfect. You're the great person for it. For people with insomnia or any sort of chronic sleep issues, they're not studied as much in that population. And we have a term called orthosomnia, which means it's actually worsening your sleep because you don't need a ring to tell you that you're not sleeping well. You know it. And they're great for sleep timing. The sleep staging is not as accurate when some like the Apple Watches will say core sleep. We don't use that term in sleep medicine. We have no idea what core sleep means. So it's like, so just keep all that stuff in mind. Now, the magnesium, melatonin, all the supplements, they really are not super effective for insomnia. I hate to say it. Some people do find magnesium can be helpful. Oh, sorry, magnesium can be helpful to relax the brain and the body. Melatonin, now full disclosure, I've worked with Natrol. Like we actually use melatonin in sleep medicine, but people often use it as a way to kind of fall asleep to, and it's actually a sleep shifter. So when we use it more for people who are night owls, who have jet lag, who are shift workers. We'll use it mostly in that population, but we don't always use it for people to fall asleep to. And if you find it's helps, great. But if you're using more than 3 to 5 milligrams, you're using too much. They market 10 milligrams left and right. There is no data to suggest that's necessary. 3 to 5 max if you want to try it.
I am neurodivergent. I was diagnosed over 12 years ago.
Yeah.
A little closer. Okay. For all of us who are neurodivergent, your planned list was great. Those were things that I developed after my diagnosis, and now in perimenopause, it feels like none of that works. I feel like my neurodivergence has blown up. It's just multiplied exponentially. But there are so many things, and finding someone who understands perimenopause and neurodivergence has been, there's a whole population of us that are struggling so much. We can't find anything for like progesterone sensitivity or too low of a dose of progesterone, the trauma, the ACEs, all of those things that are playing into it, how it's our nervous system that may be also causing us struggle to be able to regulate in this time. I'm getting overwhelmed already. Just trying to say all of these things, but the fluctuation is also, since apparently we're hypersensitive to the fluctuations in perimenopause, just is there any one that we can talk to or I can look towards, or any more books? I feel like I've been here about 5 years and I feel like I've read everything and still trying to find an answer. If there's any way to learn more, I guess would be. And thank you so much for being here, everybody.
Well, thank you for that question. And that's why I'm so glad you said it, because you know how I said that we each have our own fingerprint? We all have our unique biopsychosocial. So when you try something that works for someone else and it doesn't work for you, you just end up feeling like a failure. Like, what's wrong with me? But what you just so beautifully articulated was that, hey, I have trauma. I am neurodivergent. I don't know what type of neurodivergence, but I'm assuming ADHD. But you have other challenges, and on top of that, you have hormonal fluctuations. So that's why it's so important to have a reflection in that process. And with my clients, in addition to organizational skills, sometimes I have to modify their treatment with both short and long-term stimulants. Like sometimes we're doing all of these different trials. The great news about stimulants is that they work right away. It's like one of those very satisfying medications in mental health because it's really the gold standard. And I may have to play around with some that you can open and sprinkle, some that are patches. I mean, we just go through all of them. There's so many new ones now. And there is some emerging data with using things like Vyvanse, which is a newer stimulant, with some of the symptoms that we're looking at in terms of perimenopausal and menopausal, brain fog and so forth. The other thing is that along with ADHD, and many people don't know this, ADHD travels with anxiety and depression. So sometimes you have to expand that biopsychosocial to include some of those, new friends, right? Because as challenges happen, you start to become depressed and anxious. And one of the symptoms of depression and anxiety is poor concentration. So now you have a whole lot to deal with, right? But what I found helpful is creating community. There's a great doctor who runs Neurodivergent Insights. She's in midlife, she's a psychologist, and she's also someone who had a late diagnosis of neurodivergence in adulthood. When she was going to evaluate her daughter, she realized, wait a second, I think I'm neurodivergent too. And I love working with her. And so look her up. She has a book for neurodivergent adults, and she has an entire community. And she talks about things like using certain forms of mindfulness for the emotional dysregulation. Because for those who don't know, ADHD travels not just with losing focus, but with emotional impulsivity in your relationships. So, it's not just about memory and forgetting things. It's also about that dysregulation that happens internally. So I think finding a community and those specific tailored resources, because there's only one you and there will only ever be one you. So try to find things that fit your narrative.
Dr. Judith, thank you so much. Oh,
Do at Neurodivergence Insights. And you can find her if you go to at Dr. Judith Joseph. I have a podcast with her. I'm so bad with the names. There's the brain fog. I'm going to accept it. I'm not going to have shame. This is what happens. I'm in my 40s and I'm not ashamed to admit it.
I think we are, do we have time for any more? We're done? Yeah. Oh, okay. We're going to bring up the next panel. Dr. Judith, Dr. Shelby, thank you both so much.
Thank you.